O'Reilly. And Deputy Alan Kelly.
Thank you, Chair. And apologies, I won't be able to do a second round because I have to do leaders' questions. Last night I had the pleasure of being at the official book launch of Vicky Phelan's amazing book, which I'm glad to say is now #1 in non-fiction, and I met a whole range of different people there who are obviously very much affected by this crisis. I took the opportunity of scanning their views and listening to them for hours with a view to the questions I would ask this morning. So the 7 questions I'm about to ask are based on a conglomerate of all of that. So I'm just going to put out the 7 questions, Chair, and then allow for response because I think that would be best use of the time. I do ask everyone in this room to answer the questions fully and directly and not in a generic fashion because they are quite specific. I listened to you, Mr McCallion, in relation to what you said as regards to providing the basic information regarding the 221 and the labs. What labs were used, what dates, etc. And I have to say, I have good time for you, but I just don't buy it. I'm not sure you do yourself. Tony O'Brien, in fairness to him, in May of last year said this information should be available within weeks. The 221, I have asked for this information in that detail since last December. It's now September. There is a reason why this information is not being given out. So honest up here and tell us. So if anything we've learned over the last year or so is that we've got to be open and honest with the 221 campaign, with the patient representatives, Lorraine and Stephen. So you're saying that it's going to take another 4 weeks to collate this information. This information is available to you. I can absolutely guarantee that. So, if they write to you today and ask for the information as you currently have it, now, whatever status it is, because I've asked them this, will you give it to them? It's my first question. Because that information is available. Don't tell me it's not. It has always been available. Because there's a level of incompetence in the HSE if that information is not collatable and available. A level of incompetence which means that we have bigger issues than we already know about. This is a very simple desktop exercise. Very simple. It would be done in 1 hour, let alone a year and a half. So please answer that question very directly. We need to know the information. I've had information on my own sampling which would suggest certain trends, but obviously we need the real facts. Second question. When it comes to, and these are specifically to INAB and to the department, representatives of INAB, I want to know, I acknowledge your apology and regret for what happened. It's very unprofessional what has happened here and unacceptable. I've been trying to piece together a jigsaw as regards Scali's second report and what happened, because this report was due in the middle of February and all of a sudden was postponed for many months. So Scali, in his response to a number of my questions, and also Dr. Scali, sorry, in his response to me and in committee meetings, has said that basically there was no exact date that he discovered of the laboratory in Salford being unaccredited. Now, I've listened to him dance around this issue, and I've listened to yourselves dance around this issue. So I want to know the following. On what date did you find out that this lab wasn't accredited, and by whom? Also, second, will you please provide this committee with all communication, written in any format, electronic or not, from either government departments, the HSE, i.e. your parent department, the Department of Health, the HSE and or the Scali inquiry, or any members of their team to this committee in relation to this lab issue. Provide all that documentation to this committee as a response. I want to know the date when you found out that this wasn't accredited, and how, and this is a question that so many people want to know, how can you retrospectively accredit a lab, and how can you guarantee that the processes, and I could read out a dictionary definition of quality assurance, how can you actually guarantee that everything went on in that lab was absolutely to the standard required. And remember, between 2016 and 2018, 91,000 smears went through there. That's not counting the free smears because we don't have those figures on top of it. Third question, in relation to colposcopy waiting times, and this is probably for Dr. McKenna or whoever wants to take it from that side. CIN3, we were told, should be 4 weeks. The target is 90% in 4 weeks. It's now at 70% and getting worse. CIN1, it says, should be 8 weeks. The target is 90% at that level. It's also at 70% and getting worse. This is a serious problem. What has been done to address this? And given the fact that HPV screening is coming in, which I absolutely want to see, and accuracy level is obviously an improvement, etc., how in the name of God are we going to deal with that? Because obviously referrals should, in a good way, be up. And what plans are being put in place in order to deal with that? Please provide us with answers. Fourth question. In relation to and this is for the department, in relation to the labs, so Scally visited 7 of the 16 labs. He accidentally gave us misinformation, which he corrected in fairness, in relation to his visit to labs. We now know in relation to one lab there was retrospective accreditation, etc. How do we, and he said that basically that it was surprising and disturbing. How do we know, given I have the schedule of all the non-visits of all the other labs, etc., how can we have a guarantee that there wasn't outsourcing of any capacity in any of the other labs ever over this period? I have a real concern there, and I'd like to get some answers in relation to this. Fifth question. In relation to the RCOG review, which results, and in fairness to you, I have learned as regards communications in this, I have to acknowledge that. In relation to this, the HSE believes that 40% of all slides will have some form of different outcome. There is 1,047 women in that review. That means 430 by that percentage will have a different outcome. That seems to me very high. So I want you to explain, given the fact that this is minuted in the steering group minutes in July 18 of 40%, how is that figure? How can you explain that figure? And please, please, please don't insult me by saying that it's down to site review bias or anything like that. Why would you think it's going to be that figure and is referenced in the minutes? In relation to last 2 questions. One is interconnected. So we've got this in the July minutes of 40%. In relation to the current situation, I have raised for a year and a half now the fact that I believe it's wrong for this length of time that the audit has just stopped. I can tell each and every one of you in this room that that is going to cause serious issues into the future. I haven't time to discuss it now, but it's going to cause serious issues, and face up to it. The quicker you deal with this, the better. The trajectory for discordance of sampling that I've heard of is actually continuing post the audit. So I want to know when the audit will be brought back, what is the proposals to do it, and why are you continuing to ensure that it is stopped? Because if you look at it based on what is going to come out in the RCOG review, I think you're going to have an elevated serious problem based on the stats that ye yourselves have stated. And last question. It's obvious that in relation to what happened as regards the accreditation of the lab in Manchester, it's obvious that there was in some way a breach of contract. So you found out about this some significant time period ago. I'm not fully sure of the dates because the dates to me seem to be confusing and getting multiple dates for this. But you obviously found out about it in January or February of this year. I would presume it was before 14th of February when Dr. Scally was meant to publish his report, but then pushed it back following questions I asked in the Health Committee to your Secretary General of the Department, who said it was imminent, but suddenly it changed. And obviously something to do with the lab in Manchester. But and other quality assurance issues. But obviously there's a contractual issue here. Now, any organisation that's competent will deal with a contractual issue of this seriousness and of this magnitude and causing such public concern pretty swiftly. So will you provide the committee with all details in writing of all efforts you have made and contact with the organisation I've referenced as regards dealing with that contractual issue? And will you update this committee now on what you have done with that company as regards that contract? Because obviously it's an issue that you would have had to have dealt with and dealt with swiftly by now. Thank you, Chair.
Thank you, Deputy Kelly. Mr. McCallion.
Yeah, I'll pick up the information on the laboratories. I mean, I've spoken to the patients actually in the last couple of weeks on this. I have no issue, Deputy, once we have agreement with the patients in releasing the information. We have, as you say, the overall breakdown. There's additional information been requested from discussions with both Lorraine and Stephen, and certainly with their agreement, I have no hesitation in that. I was spoken to Stephen.
You have it in writing today?
Yeah, that's fine. And certainly we're happy to work
release
with
the
them
information today or tomorrow. Grant, thank you.
Maybe on the colposcopy, I'll ask Dr. McKenna to...
Yes. I think this is mostly dealing with question 5, Deputy Kelly.
Yep.
The HSE has taken the disclosure of the RCOG audit as a matter of the utmost importance. There were a lot of unknowns in this. We didn't know when the reports were going to come through, and we didn't know the discordant rate. Consequently, our plans were based around a discordance rate of 40%. We had to plan for something, and so we picked something at the upper end of the likely range. Other audits like this would have shown a discordance rate of 25 to 35%, so we would plan for the worst possible case, which would be 40%. We haven't got all the reports back yet, but the evidence that we have would suggest that it's going to be substantially lower than this. What I can tell you is that the priority group, which consists of all the discordant smears, the 221 that took part in the RCOG review, patients that have deceased, patients who had an interface with colposcopy, and patients whose slides have been either lost or broken, that the total number of these patients comes to in and around 400. So based on this fact, I think it's reasonable to say that the discordant rate is likely to be substantially less than the 40% that we were planning for. So that's how the figure was arrived at. It was done in order that we could get our plans in motion. I'm not in a position to give you the absolute discordant rate yet, I should say, but the hope would be, the expectation is that the plan was on the high side.
Okay.
I think maybe just Peter, it might be Dr. McKenna might just speak also to again to reiterate the plans around colposcopy and the pressures that are there and the impact assessment that's been undertaken.
The colposcopy waiting time has been addressed locally by people putting on extra clinics where they were doing 2 or 3 a week. This would have gone to 3 or 4. This is what they can do quite easily. What they cannot do is deal with the number of increased clinical referrals. And what I had said earlier is that the expectation is that we will be planning to take those out of the colposcopy clinics and let the colposcopy clinics deal with abnormal cytology and positive HPV. I would think that if we can reduce that number of referrals by what we know to be 30 to 40% of the colposcopy workload, that the HPV work generated can be accommodated relatively easily.
I don't know if many people agree with that.
Well, I'd be very interested to know which element of it you are sceptical of.
Scale.
Pardon?
Scale.
The increased referral from by HPV is quite variable. Some people have reported increased rates of 10 to 15%, other increased rates of 40%. I would have thought that if we can take the clinical referrals out of the colposcopy clinics, which, as I say, currently account to 35 to 40%, the increased rate of HPV should be accommodated.
Well, let's see if you're right.
Pardon?
We'll see if you're right.
I think, Deputy, as Dr. McKenna said, like, no one's saying it's not a challenge in terms of what's there. There's a significant piece of work
we've had
going
time
on
to prepare for it.
No, and we have an investment which is going out at the moment in terms of additional funding from the service plan this year, and we do think that we'll need more, and we will work that through.
But the figures as regards what I quoted there are accurate and are going south.
Correct.
So, I mean, perform a miracle, and I'm taking your word, Dr. McKenna, that the miracle is going to be performed.
Well, I think there's two challenges that allow Dr. McKenna to come in. Then one is the current pressures in relation to, and that's where the funding has been targeted to address that, and the hospitals have been engaged. And secondly, then, is the HPV piece. Maybe Dr. McKenna has visited all of or most of the sites, so you may wish to speak to that.
Yes, I'd just like to clarify to Deputy Kelly, in case he thinks that there's, I'm claiming that we're going to work miracles in this. I'm very grateful to him for his interest in this, because it is going to require additional resources to do this. It is not going to be resource neutral, and any help that we have in procuring these resources is, of course, entirely welcome. It would be particularly welcome by the colposcopy community, who are very conscious of these waiting times. This is a group of individuals who are very committed to dealing with their patients in the appropriate length of time, and certainly they would be very appreciative of your interest should it in fact help to resolve.
It's not the first time. I've been raising this for some time.
Pardon?
I've been raising this for some time.
Well,
you're on the record as regards my concerns. We'll see what will happen in the future. I'm conscious of time and the other questions.
Sure, I'll pick your question just on the Manchester and Medlab, the contract arrangement, Deputy, and maybe my colleague beside me, Dr. Henry, will pick up in terms of the interval cancers. Just in relation to Medlab, Medlab have ceased as a provider with the programme, and there's no further work going through Manchester or Sandyford. So in that regard, the contract has concluded.
I understand that, but obviously there was breach of contract, so what do you do about it?
So I suppose we were locked in negotiations. It was one of the factors in the negotiations with Medlab in relation to the continuation of the contract with Medlab and how we dealt with that. And I suppose it was dealt with in a composite way around the termination of that work. So
no, there's a breach of contract here. There's a consequence. We were paying as taxpayers. There's a breach of contract. Obviously, there has to be something that will come back from this. What did you do about that? So
this was part of a wider negotiation, Deputy. We couldn't look at this issue in isolation. We were negotiating a contract in relation to the future of the programme. The programme at that stage was on the verge of collapse. So we looked at that in the whole. Our priority in terms of Manchester was to get assurance in relation to the performance of the screeners in the laboratory were included within the Medlab screening performance, which we are assured they were. And we looked at it in that context to make sure that there weren't issues from a performance perspective. In the wider context, we had to negotiate around this.
Just to save time, what I'm reading into this is basically nothing happened.
No, Deputy,
there was no consequence to them.
It was a factor in the overall negotiations. We could not look at that in isolation. There was a contract negotiation that was more complex.
I don't accept that one bit. Sorry, I'm conscious of time.
Sure, I'll ask Dr. Henry maybe to talk in relation to the interval cancers.
Yes, thank you, Deputy Kelly. I entirely agree. Interval cancer audit is one component, but a very critical component of quality assurance measurements of screening programmes, not just in Ireland, but internationally.
No, all about interval cancers, but I didn't ask a question on it. I think you were referring to trying to get around to the audit issue, are you?
Yes, I'm trying, if you could give me time, Deputy, I'll try to answer your questions. That's okay. I will be brief, but I think I need you to give me some time to answer this.
No, it's not that at all. It's purely about the audit. I'm conscious of the chair.
Yes, in international screening systems, the interval cancer rate is often measured because there are population-based screening programs. For example, our own breast screening program has an interval cancer rate which compares very favourably internationally. And the events of last year showed us, and Dr. Scally's report showed us, characterised existing audit has been flawed in design, in implementation and the way it engaged with clinicians. So following the publication of the Scally report, we committed and are well advanced in designing interval cancer audit for all 3 cancer screening programmes. We have expert groups led by independent chairs. We're scoping out international best practice. For example, in Canada, all audit or quality assurance clinical activities are protected in legislation, while in England and Wales, a duty of candour legislation came in, I think, in 2014. making it almost unique in bringing in not just open disclosure with regards to certain elements of false negativity. So what we don't want to do is just reintroduce what was characterised as a flawed audit. So the work of these three groups has come into a conclusion, and input into those came not just from international experts, from patient representation and advocacy groups, and I'm confident that we'll have an output from these groups towards the end of this year.
When will the audit commence?
When
will you have the audit back in place retrospectively to 2016?
We won't have the audit last year back in place, Deputy.
I know that.
No,
but when
we
will
will
you have an audit?
The question is, we need an audit that everybody can stand by.
Fine.
And the work of this group will come to fruition towards the end of this year.
When will the audit be in place?
After that comes through, we will clearly validate it here in the HSE and with the Department of Minister.
I agree with all of that.
We want to get it back up as soon as possible.
And that will go back to 2016?
Well, what we were looking at is a prospective designed audit, so what we do from here on out.
So you're going to skip to years 16 to 19?
There's no intention to skip, Deputy. What we need to do is, as I said, we do not need to implement what is characterised as a flawed audit.
What's going to happen to 16 to 19 or 20? Because this is new information to everyone here. If you're going to have it from 20 on, but there's a gap there, what's going to happen?
What we're designing is something prospectively, which includes open disclosure in certain circumstances and scoping best international practice.
So 16 to 19 will be covered?
There's existing quality assurance mechanisms.
No, it's not. Will there be an audit for 16 to 19, yes or no?
We look at each individual programme, Deputy. There's no intention not to perform audit, not to carry out quality.
So there will be?
Yes, we will look at each.
So there will be an audit. That's what I'm taking. If I'm wrong, just contradict me. The last question was to lads in INAB, and I'm conscious that they're waiting with bated breath there to answer.
I want to be as clear as possible and provide the exact dates on the questions that you. Sorry, can you hear me? To be as exact as possible on the dates on the questions that you've asked. So as I said at the outset, MedLab have been accredited by INAB to ISO 15189 since 2011. And in order to confirm their accreditation on an annual basis, we carry out on-site assessments with consultant histopathology specifically in relation to cytoscreening. So to directly answer the questions that you asked, with regard to our communications as part of the scoping inquiry, in November 2016, MedLab emailed us about information regarding recruitment of a cytoscreener and that they intended to locate that cytoscreener in the Manchester office. And as we said in our opening statement, we should have followed up more robustly at that stage on that information that was provided. On the 8th of February this year, Dr. Scally sent that email to me about a copy of that email that we had received from MedLab at the time, and with the specific. Have you
supplied all that documentation to the committee?
Yes.
Okay.
Yes, Deputy, yes. And on that basis, we carried out a thorough internal review at the time in conjunction with our technical assessors, and based on the evidence and the facts in the MedLab file at the time, we were able to confirm, or we do confirm, that the cytoscreening carried out in the Manchester site is accredited by INAB.
What date was that? Was that the date that's down on your 30th of May 2019?
Sorry, the date of which, Deputy?
The date you gave accreditation.
No, we are confirming that accreditation is in place for MedLab under 15189 based on the review and based on the annual assessments that we undertook to MedLab from 2011 right through to 2019.
No, that's not what I asked. I mean, there was no accreditation there. So the accreditation, according to Dr. Scally's letter to me, was that the schedule was numbered and dated as edition 1, sorry, I read the wrong one, edition 2. So it was accredited on the 23rd of 10, 2018. It didn't have, it just had Sandyford Business Park, Unit 3. It didn't have Manchester. But by the 30th of the 5th, 2019, it had Manchester. That's according to your own schedule. So
that's right.
I want to know on what date, and this is a very important and specific question. You were notified on the 8th of February by Dr. Scally in writing. I want to know on what date you gave accreditation to this lab.
If I might just put it in a different way, Deputy.
I know, sorry, it's a very specific, I'm sorry, I'm cut for time. It's a very specific question. I've asked this question so many times in so many different ways to Dr. Scally, his team, to the Department of Health and to the HSE and to everyone else. I want to know what date you gave accreditation to this lab.
Based on the evidence from the assessments that we carried out on an annual basis to 15189, which reviewed the competency of all the CITER screeners, all the equipment involved in the CITER screening testing, the release and issue of results, we confirmed to Dr. Scally in a letter, an email of the 13th of February, that the activities, the CITER screening activities carried out by MedLab Pathology at their Dublin and Manchester sites are accredited.
So it's the 13th of February you gave accreditation?
No, we confirmed to Dr. Scally that accreditation was for the Manchester and the Dublin sites based on the evidence, the factual information that we had and the depth of our assessments that we carried out on an annual basis.
No, that didn't answer my question. But you've now even thrown another date in here. So on the 13th of February, you confirmed that it was accredited or not? And what's the differential to everyone watching here? And remember, some very, very senior people are watching what we're saying here. What's the difference between what you wrote to him on the 13th of February and the schedule edition to 30th of May 2019, which is where you next say that lab is accredited, as distinct from the 23rd of the 10th, 2018, when you just said Sandyford was accredited? I want to know the difference between what you said to, and we're really just focusing in here now. I don't know why my question can't be answered directly. I have to zone in here. The 13th of February and the 30th of May.
The difference, Deputy, it goes back to what we have said in our opening statement, is we do accept that there was a lapse in our procedures in terms of the depth of follow-up and the timeliness of our follow-up. And following our engagement with the scoping inquiry, we did carry out an on-site assessment to MedLab Pathology, and this included both their Dublin and their Manchester sites. It was the 17th and 18th of April 2019 and a third date in May 2019. And that is part of the annual assessment to MedLab, which assesses their entire scope of accreditation with technical experts. And following that on-site assessment, we did regularise our paperwork, which we accept there was the gaps in our procedures, where we should have identified
we understand
the Manchester site.
We understand that. But one very last time. So we now know that November 16, they emailed you. There wasn't a follow-up, and you've apologised for that. I accept that. That's not my major issue. We now know that on the 8th of February, Dr. Scally wrote you as he found out about this. Okay, and I've already asked you to provide all, and I mean all, communications from Dr. Scally, his team, to either department, including your parent department, and or the HSE or cervical teams, to the committee. If you have any issue with anything like me saying that, any problems with that, please tell us now. That's the first thing. What I want to know, what date INAB, as the accreditation body responsible, and I can't be any more direct and specific, gave Manchester Lab, MedLab's Manchester operation, accreditation. We have 3 dates knocking around here now. We have the 13th of February, we have the 17th, 18th of April, we have another date in May, we've actually 4, and we have the 30th of May. So unless I hear a specific date from you to tell me what date your accreditation body, as an accreditation body, you gave this lab accreditation, I want to say on the record, Chair, that INAB are unable to provide us with a date for when they accredited the Manchester lab. And I want to be contradicted here and now by being told the exact date that the Manchester lab was accredited. It's a pretty basic thing, and I think the public deserve to know it. And furthermore, it's kind of incredible if there isn't a date. It's not believable that there isn't a date where this accreditation was actually given by an accredited body in this state.
Dr. Duff.
What we are saying is that as part of our review with the engagement with the scoping inquiry and based on a full technical review of the evidence that we have gathered over our annual assessments to MedLab, the fact that they were operating a common system of management across their sites, we reviewed the competence and the quality assurance of the CITER screeners involved in the testing. We reviewed the application of their common management system, their control of the laboratories and the staff involved. We are saying that the CITER screening activities performed at the Manchester site have been accredited since they started.
So they've always been accredited?
Based on the evidence and the technical review that we conducted, we are satisfied that there's a common system of management in the laboratory, that we did assess the competence.
So a lab that nobody knew about, the HSE didn't know about, wasn't part of their contract, INAB never knew about, was always accredited. This is scary stuff now. Scary stuff. Scary stuff.
Just to,
Just one brief
has,
question. We're going to move on to
in the history of INAB,
Senator Burke.
so just
Yes.
can I follow?
Yes.
In the history of INAB,